Salt and pepper disc chromatosis. Is the broadcast okay for the online students? Good. Where do you see? In our patients, Lachakka Buchava from the village who had scleroderma, entire skin got thickened, shiny, right? You find hyperpigmented areas interspersed with hypopigmented areas. The combination will give as such salt and pepper is being spread on the plate. Is a typical feature of scleroderma, is what need to be remembered. So what is wrong about leprosy? Leprosy is not highly infectious disease, unlike the tuberculosis. What is wrong about dermatophytosis basically? If there is a mucosal involvement, it cannot be a dermatophyte. Tinea cruris, Tinea unguum, Tinea sconlini. No tinea ever like to stay in your mouth. That's a simple truth which you need to basically remember. So if there is any mucosal involvement or if there is any red scaly skin rash, generally how will be a dermatophyte infection? Typically there is a central clearing will be there. If that is not seen, that beefy inflammation is still visible, then it is unlikely to be dermatophyte infection. What is wrong about lichen planus? It is not extensor but a flexor surface where you find what are 5 P's about lichen planus. P for pruridic, papular is P, polygonal shaped, purpuric, pruritic, papules are the classical feature of lichen planus. Now what is wrong about plaque psoriasis? So whenever there is an acute flare of a plaque psoriasis, it can evolve very much into erythrodermic psoriasis is what you have to basically understand. Antidesmoglein antibodies are a feature of pemphigus vulgaris, as all of you know very well. Then lepramin testing. Lepramin is only a prognostic but not a diagnostic test. Only if the cell-mediated immunity is intact, then only the lepramin testing will be typically positive. Hence tuberculous type of leprosy, you have positive lepramin. Lepromatous leprosy, you have a negative lepramin. We had been studying this since times immemorial. Wood's lamp, what is the wrong statement? Typically the Tinea cruris, cutaneous candida, they do not flourish under the Wood's lamp. So obviously you should remember and should not forget, examiner is very interested to know which color, which organism. Tinea versicolor. Once more, this dual terminology in dermatology is very difficult. Tinea versicolor is same as pityriasis versicolor, which is different from pityriasis. Alba is different from pityriasis. Rosea is different from pityriasis. So many pityriasis are floating across dermatology textbook. So pinch purpura. If you pinch purpura will develop. What is your answer? In primary systemic amyloidosis. This is a classical patient of pinch purpura. You pinch, you get purpuric lesion is what you have to ultimately remember. So face, especially periorbital, perimoral area, you are having pinch purpurae of amyloidosis. Typically the nail changes, where do you see doctor? Which are suggestive of psoriasis, pitting, onycholysis, oil drop sign. Where do you see half and half nail? First let us see, this is called half and half nail. When you go back to the hospital, check, go to the nephrology department dialysis unit and check the patient undergoing hemodialysis regularly. You will find half and half nails called Lindsay's nails is what need to be remembered. The present examiners are little good guys. Old days mein, MD final year mein only one question. You have to write 3 hours essay on that. MD General Medicine final May. So my professor got the main, he never studied about nails and Kabibi Hutchison and all those things, he never studied. Write about nail changes in systemic disease. Only one question, 3 hours. Agar nahi malum hai to khel khatam, dukan band jao. From that time, he failed actually in MD final. He doesn't know anything. He is not prepared. He is prepared for TB, congestive heart failure, so many topics. There was only one question, no choice. So from then onwards, every time you say nail, he become irritated in the ward rounds. There will be some triggers, you know, for the professor in the ward rounds. You should know what triggers. By the time first 1 month of MD is all about knowing the triggers. You need to do patch test quickly. What are the allergens? Maybe your seniors will tell. Second year, third year already they diagnosed it, no? They have done complete skin inch to inch analysis of the professor and HOD. So they will tell you these are all the possible triggers of type 4 hypersensitivity, type 1 hypersensitivity, nocturnal hypersensitivity, morning pruritus, everything they will tell you. So you should not become an itchy postgraduate. Asbo-Hansen sign. Where lateral pressure on the edge of the blister, if you apply, the blister becomes spread into the unaffected area. I will show you. Whenever you apply lateral pressure, the blister becomes spread into the adjacent unaffected area. That is a very important sign which is typically seen in pemphigus vulgaris, is what you need to remember. It all depends upon whether it is intradermal or subepidermal blister. All this game is about ballooning, unballooning the blisters of the patient and putting one named sign for everything. The main factor involved in psoriasis is what? Hypoproliferation of epidermis, increased keratinocyte life cycle, decreased sebum production. They are all the things which are accept or not accept about it. Proliferation should be more, no? That's what. I think here we will, except came up wrongly, I believe. Yeah. Wrong except about except. Now, what is the first sensation lost in leprosy, doctor? Temperature is the first sensation. But first sensation as a resident, we will check it for not temperature, no? A leprosy patient is there, examine. First thing, what will you do? You take the needle and start pricking him until he cries that he is feeling the pain. You don't carry that warm bottles and check his temperature sensation. But entrance ke liye you will read all this panda. It's not applying on patients also. What is wrong about Pityriasis rosea? A single outbreak elicits a lifelong immunity in Pityriasis. Only one Christmas patient will have, not Christmas every year. Christmas tree pattern, So that is the point you need to basically remember. Then it is an upper respiratory tract infection which predisposes to a wrong cross-firing of our immune system leading to the development of this. So Pityriasis rosea, one time aage to it will give lifelong immunity. About tinea versicolor, what is the wrong statement? Just 3 weeks of regime of oral ketoconazole will not eradicate the malassezia of furfur, which will lead to, what is that appearance called? Italian food in tinea versicolor. Spaghetti meatball appearance, you remember, no? So, this is the typical in tinea versicolor, right? Tinea versicolor, alright. So, 1 tablet a month of ketoconazole, fluconazole, itraconazole can be given prophylactically to prevent recurrences, but you need to give intermittently throughout the year. That is considered to be the principle. What is the most common nerve involved in leprosy, doctor? It is the posterior tibial nerve. Target lesions are a feature of erythema multiforme. In mycosis fungoids, what will you give? Full skin electron beam therapy, right? Then pseudobubo is a feature of donovaniosis. 6-month-old has got itchy erythematous lesions. Classical location. makes you to think of scabies. Greaseolfulvin is not effective where? It is not effective for candida. It is not effective for tinea versicolor. But commonly candida means okay, greaseolfulvin tablet de do is a common tendency, right? So systemic fungal infections, amphotericin. All dermatophytes give greaseolfulvin. Generally our tendency is any itchy lesion in the genital area means we tend to say give greaseolfulvin and forget about it. You should check what is the underlying cause. All tinea except the tinea versicolor is what you have to basically remember. Where do you do oral examination is a very important question. Peutz-Jeghers, classically you have got the iron deficiency, esophageal webs, etc. etc. So then, mycosis fungoides. What is not a true statement? Mycosis fungoides is a serious diagnosis. Cutaneous T-cell lymphoma. So it doesn't carry a good but a poor prognosis. LGV is caused by Chlamydia trachomatis. Ustekinumab. You thought you are done with abs only in general medicine? No. Monoclonal antibodies, one question definitely come and that will be haunting you, pervading your peace even in dermatology. And what is that ab that you are going to remember? Ustekinumab. Stellara is the typical drug name. You don't need to remember Stellara, but you need to remember Ustekinumab. IL-12, IL-23, it is effective, typically used in the case of the psoriasis, is what you have to basically remember. That's the reason I am saying, preparation for MD entrance is no more enigmatic. You need to have a good smartphone, or a tablet or a laptop, whatever. Have good Wi-Fi connection in the reading room or wherever you are studying. Go to YouTube and say Ustekinumab injection. You will find a guy injecting into a psoriatic patient Ustekinumab and the psoriatic patient's lesions vanishing. All this you can see in a video if you don't want to remember it otherwise simply. But make your preparation interesting. That's what I want to tell you. Now, doctor, what are the triad of clinical features in case of the graft versus host disease? Dermatitis, enteritis with diarrhea, hepatitis with abnormal LFT, high fever, conjunctival erythema, they are all the important features. Lupus pernio, where do you see, doctor? These are the violaceous, duffy infiltration on the nose, cheeks and earlobes. Typically seen in the case of the sarcoidosis is called lupus pernio. Lupus vulgaris is TB, very good. Eruptive xanthomas are a feature in which hyperlipoproteinemia is only 1 plus 4 is equal to 5. 1, 4, 5 only you find eruptive xanthomas, which are those yellow papules which are seen whenever there is a hypertriglyceridemia. Indirectly asking which hyperlipoproteinemias may you have hypertriglyceridemia. All are not hypertriglyceridemia. I think you know triglyceride is different from cholesterol. Some are mixed, some are only cholesterol, some are only triglyceride. So you must know 1, 4 and 5. 1, 4 and 5. Tombstone row appearance, already we have discussed it, of the basal cells, pemphigus vulgaris. Paraneoplastic pemphigus, commonly NHL, non-Hodgkin's lymphoma is associated. Already we have seen carpet track sign. Oh, we have not seen carpet track sign. If you raise the carpet, follicular flux will be seen with the removal of the scale is called carpet track. Is a feature of discoid lupus erythematosus. Carpet track sign and follicular plugging on the face, scalp and ears called concus bowl. These are all the features of cutaneous discoid lupus erythematosus. Pitting of the nails is a feature of eczema, alopecia areata, and also in case of the psoriasis. Then Marfan may, this kind of questions will be creating a Venki back phenomena in the exam hall, because we know fibrillin, but fibrillin 1 or fibrillin 2 before we give you the seat, laddu into your hand. So it is the fibrillin 1 mutation which you need to be quite sure about. Marfan is fibrillin 1, congenital arakinodactyly is fibrillin 2, Buschke-Swellendorf is desmosine. You don't need to remember all that idiotic stuff. Marfan, fibrillin 1, too much for this life. Pray God and go ahead. You need to move forward. Otherwise, petty entrance books. Fellows like us will be writing lot of unnecessary stuff also and throwing into printouts. Don't be carried away. But fibrillin 1 is high yield. That's very important. To regulate the body temperature by evaporation, you require eccrine glands. What is the most definitive HLA association, doctor? It is the HLA CWR. CW6 is what you need to basically remember. B8 is dermatitis herpetiformis, lichen planus. B51 is known to be with Behçet's disease. B27 anyway you know, lot of conditions. Seronegative spondyloarthropathies. So out of all this, what is the mismatch? How do you like to describe seborrheic dermatitis lesions? Typical salmon colored, scaly patches and flocks involving the scalp, groin and intertriginous areas. What are the two subsets of population who have a high tendency for seborrheic dermatitis? Any answer? Parkinsonism patients and HIV positive individuals. They have a high tendency for seborrheic dermatitis. Don't confuse it with seborrheic keratosis. That is different. Seborrheic keratosis have got a stuck on appearance. You take a little dung and stick it to the wall. We see in villages, no. Like that, lesions will be found of keratosis. That is different. Sudden appearance of such seborrheic keratosis, what is it called as? Sign of lesser Triad. It is called as sign of lesser Triad. It is a sign of internal malignancy. It is a cutaneous sign of internal malignancy. If there is an internal malignancy, sudden appearance of seborrheic keratosis, sign of lesser Triad. And they have got a stuck-on appearance is another important question asked in the exam. About seborrheic dermatitis, what is asked in the exam? What are the conditions where you see? You see it one in HIV positive individuals and Parkinsonism individuals, you find this typical salmon colored scaly patches and flocks. But in a newborn baby, if you find it, what is it called? Cradle cap. It is a very benign feature. There is nothing to be worried about it. What is the treatment of neurosyphilis? Typically, neurosyphilis, very good. Our Kakinada students are sharp about answers. HIV, Parkinson's patient is an answer coming, doctor. Remember, when you are preparing, 1 lakh students are also, when you are dreaming, 1 lakh students are dreaming. For the same MD, 10,000 MD seats available. When you are preparing, probably out of that 1 lakh, 4,000 to 5,000 are also preparing. Don't expect all 1 lakh will come prepared to the exam, right? 4,000 to 5,000 will also be preparing. But when you are preparing seriously, maybe another 600-700 people are preparing seriously. So what is the idea? Prepare seriously. Another 5 to 6 months. Most important, not knowledge explosion. Limited things, precisely. What is commonly asked, go to exam. Don't worry about surprises. Surprises will always be there. 20-30% is a surprise element. But 70-75% is predicted element. Right? So predicted element will be there. So if you are not prepared for the predicted element precisely like an army soldier, when to fire the gun. If you are not ready, You are still greasing the gun when the question is firing on you. No one can help. Otherwise, everybody have to, natural adrenaline will raise, common sense you will use and you will answer, and you will make guesswork and you will answer. 15% you will get out of that 30% surprise element. Anybody will get. Because we are all brilliant students to get into medical college, no? We are not dumb. But 70% we lost the habit of working hard. Right? But that 70% if you are not prepared, you are scoring only 50% in that. And you are getting 15% of the surprise element. Only 65% doesn't give you the seat. You need to get 75 to 80% open competition if you want to get a good seat. So that's the reason, prepare for the predictable part in a predictable manner to give a predictable answer. Then neonate with bullous skin lesion with periosteitis is a music into the ear that it is syphilis. And for the syphilis, what will you do? VDRL. A patient has got a hyperpigmented macule on the trunk and multiple hyperpigmented macules in the axilla and groins since childhood. What is that neurocutaneous syndrome that comes to your mind, doctor? So Lisch nodules are the ones which you need to check for. A diameter ovoid erythematous slightly raised with a coronet-like scale appearance. Classical feature of pityriasis rosea. So the herald patch, cigarette-like scale at the margin, oblong trunk lesions of Christmas tree pattern along the lines of Langer are the classical feature of the pityriasis. Local electron beam therapy, where do we use in case of cutaneous T-cell lymphoma, Séjourné syndrome? Séjourné syndrome, local electron beam therapy you will be doing. Lepromatous leprosy, nerve enlargement is an early feature. Is an early feature. Pityriasis alba, why does it occur? 7th class, 8th class, 9th class, white lesions. So the boy will be worrying, he will never get a girlfriend in life. But later on he discovers he is the cutest guy when he enters medical school. Right? So it is only transient. Puberty, lots of puberty. When it starts, testosterone start pumping, pityriasis alba also start appearing. Right? Pityriasis versicolor, like lesions, where do you find? In case of epidermodysplasia verruciformis, idiotic question. This won't recur in exam. This is not a predictable question, I am trying to tell you. Now, pemphigus caused by black fly, what do you call it as? It is called endemic pemphigus foliaceus Phogos-selvagem. Sounds like a Tamilian Sri Lankan name, right? So, Phogos-selvagem is a autoimmune organ specific blistering disease in which desmoglein 1 antibodies typically appear. So this is a typical Phogos-selvagem. Autosomal dominant systemic amyloidosis. It is typically called Muckle-Wheel syndrome. Another idiotic question, they won't ask this. Airborne contact dermatitis, why does it come? Parthenium, what is it called? Congress gas, nothing to do with our Congress. So it is called Parthenium hysterophorus is what need to be remembered. In psoriasis you have reteridges and hyperkeratosis. Civet bodies, what are they, doctor? They are those apoptotic keratinocytes in the basal layer, which you see in case of the lichen planus. In lichen planus, you will also see hypergranulosis and lymphocytic infiltration against the undersurface of the epidermis. These are all the features of the lichen planus. Hypergranulosis, civet bodies and lymphocytic infiltration underneath the epidermis. Pemphigus vulgaris, antibodies are against the intracellular substance. Burrows are burrowing into stratum corneum. These burrows is corneum because they burrowed into corneum. Then osteotic eczema. What is fact about it? So the word is eczema and it looks very benign. It is not a pre-malignant lesion. It is truly benign. Tinea versicolor infection, they use selenium sulfide shampoos, salicylate, imidazole, but not corticosteroids. Phototoxic reactions can occur with tetracycline, thiazides, quinolones, chlorpromazine. Another very high yield question. Phototoxic reaction causing drugs. Among tetracyclines, once more, which is most phototoxic, which is most, so many toxicities are there. Renal toxic, hepatotoxic. Chapati, you are Tripati and chapati, you are completely ready with the batter. So you have to, pharmacology. Our pharmacology is not yet over, no, in the subject is, I think it may be coming in the schedule. So, what is not correct among these statements? Who said all upper pili are palpable? No. Palpable pulpirae are vasculitic purpurae, impalpable purpurae are thrombocytopenic purpurae, as all of you know very well. Skin pigmentation is a feature in all these scenarios, but not in Cushing. How will you identify Edison's disease patient, doctor? A hypotensive, dull looking guy, lying down completely asthenic in a ward. Nurse will tell you, doctor, 2 bottles of saline gone inside, but BP is not improving, 90/60. What do you suspect? Edison's disease. Edison's disease is what you need to remember. What is the cause of the Edison? Edison is not another common confusion. Autoimmune destruction of the adrenal is called Edison. All Edisons, all hypercortisolic states are not Edison. But Edison is hypercortisolic state. But what is the commonest cause of the hypercortisolism in India and adrenal dysfunction? TB. Tuberculosis destroys the adrenal is what you have to basically remember. Then one more important feature. Where is the pigmentation in Edison? Classical. Knuckles area. What else you are able to see in this? Are able to see his nails, doctor? Candidal infection of the nails. Candidiasis plus Edison, you heard one syndrome called polyglandular autoimmune syndrome, right? That is different from men, no confusion. In general medicine, we will have a complete marathon of all those things. Hypertrichosis, minoxidil will lead to disoxide, cyclosporine, but not alpha blockers. Scalp pruritus, cervical lymphadenopathy. What is your diagnosis? Pediculosis. Pediculosis comes to your mind. Chancroid. Typically, chancroid is different from chancre. Chancre is syphilitic, penicillin is used, but not in chancroid. So, Haemophilus ducreyi, we use azithromycin, ceftriaxone, ciprofloxacin, etc., etc. Friable bleeding ulcers, classical question. Granuloma inguinale. Drug-induced pemphigus commonly shows a pattern of foliaceous, which we have seen in the earlier question. In psoriasis, what do you see? Psoriasis. Spongiform pustules, Munro's abscesses, parakeratosis, these are all the features of psoriasis. Bowens is classically considered to be a precancerous lesion, not the seborrheic dermatosis. Seborrheic dermatosis is a feature of seen in Parkinsonism, HIV, etc., etc. Dermatitis herpetiformis, we use dapsone. Pseudodiarrhea. Diarrhea is seen in case of urticaria pigmentosum. If you scratch, there is a blister, eruption. Congenital smooth muscle hematoma. Stupid question. This won't come in exam. But still we will give you, because we also need to give you the 30% unpredicted questions, no? So that we tune your mind to accept that you need to accept that there is a God above in the heaven. He is watching us. So, how do you know? If you have questions you totally don't know anything in spite of finishing entire dermatology. Right? So, don't worry about this kind of questions. Scraping the surface of the lesion in pityriasis. By the way, why it is called pseudodiarrhea? Basically in this, Just like diarrhea it occur, but not because of the urticaria pigmentosa. There is a temporary induration and piloerection after rubbing. If there is an underlying smooth muscle, hamartoma. Scraping the lesions is typically called as Coupe de Ongol sign or Anglais sign, whichever. So, Auspid sign, one more candle, tray or candle light or candle knife, grease, oh, I forgot what already I taught. This is Auspid's, pluck it, find a petechial lesion. Then scratch sign. Scratch sign is also called Coupe de Ongol sign. Then comes Nellore sign. Many other signs are after this. Satellite papules. Where do you see, doctor? Classically. In case of the borderline tuberculoid lesion, you find satellite papules is what you need to basically remember. Thank God.